these health facility governing committees. On the PPP front, at local level, is not developing as well as it should. Service agreements are not really actively maintained. There is room for improving dialogue, particularly at the periphery, so that our policies are not just rhetoric, but they become practical on the ground. I would leave the slide on regional reference for Dr. Berege to present.
Madam Chairperson, distinguished guests, ladies and gentlemen, thank you, my team leader, for allowing us to present this in front of the august audience like this one. You'll have to look at the strategic directions that were very well posted. These are just few and summarized, very well summarized. But the key findings are in the service delivery, in the regional hospitals are improving, services are improving in terms of quality systems and procedures like SOPs, and also better implementation, let alone some few differences. Then added to that are the electronic medical records that are being introduced. These are fastening the procedures, they are fastening the processes, they are reducing the time, and also they are user-friendly. Somebody comes at a clinic, he spends a few hours, a few minutes, and goes away. It's nasty to go at a clinic without an appointment or with an appointment, and you stay for hours without getting the services you desire. But this is also hampered by the staff. We have quite a critical shortage of staff, particularly in the regional hospitals. Our colleagues were saying, why do I have to refer a patient from a district hospital where an AMO is to a regional hospital where there is an AMO? So that is an anomaly. So refer a patient from one level and goes to the next level and makes some kind of an expert who is better knowledge than the other level. So we have shortage of critical staff at appropriate levels in the regional hospitals, particularly the 4 disciplines, clinical disciplines. Now we also have some other disciplines like the radiography, laboratory technologies, but these are not yet there. Then the other issue is on the management. It's a serious issue. Where you have a better manager in the regional hospital, you have better performance, better coordination. The word coordination, the word quality has been mentioned in all the reports here. So I'm sure Mzumbe had started a college or a course on management by the health secretaries, but that one somewhere fizzled out. We don't know why. DMOs are going on training, RMOs are going on training. We said RMOs and DMOs should be public health specialists. We suppose that they have better management knowledge, but that has not been the case. Also, we need somebody to oversee this kind of management. Health boards. Some regions do not have health boards. Hand with the health board. That health board is an advisory board to you. It will assist you to track whether you are doing well or you are not doing well. So don't despise that one. Take it that this is an advantage to you. And we have seen regional medical officers who work hand in hand, in cooperation, in collaboration with these structures. They do very well. Next slide, please. Then on the curative care, we want to maintain a high level of disease control programs. True, we are talking of curative services, but don't forget the promotive services as well. We want to reduce mortality and mortality caused by infections. My colleagues have talked about infectious diseases. So prevention and screening in the disease control programs perform much less. We would like to see more preventive aspect in the regions. Although you are supposed to do some critical work, would like you also to put in elements of screening processes. You should know, why do we have so many inpatients? Why do we have so many outpatients? What is the problem? So make a little bit of research. Then at grassroots level, my colleagues have said of integration of work in the health facilities. Well, integration should be there. If you involve yourselves as a teamwork, and I'd like to urge the RMOs, the MOs, all those who work in the hospitals, in the institutions, to develop a culture of teamwork. Work together. Amesema mama hapa, tutembee pamoja. You should also know what you are doing, what is happening, where, and what has gone wrong, and what measures you can take. That has to come up very. At high levels, logistics planning, care, monitoring, evaluation is separate. We accuse of development partners, but I think sometimes it is ourselves. Development partners are there to assist us. So work with development partners. You have seen that they have vowed that they work with the Ministry of Health and the government. So let us use them and see what they know best and how they can give us some pieces of advice. Then we have forgotten neglected tropical diseases. We had a program of neglected tropical diseases, but it fizzled out. Why? We don't know. But something is happening. At least some action plan has been developed. But whether this is going to continue or not, it leaves us to look at it. Next. Then on the NCDs. In the villages, you see people are dying, and what has he died of? He just fell sick. He fell down while drinking some alcohol. You say, because of alcohol. It is not because of alcohol. Maybe he had a high blood pressure, maybe he had diabetes, and that was not attended. It was not even noticed. And you do not take critical histories, you do not take critical issues which you can sort out. Then, of course, no results. This has been posted purposely. Why no results? Because the community does not have the knowledge about NCDs. Even the health workers themselves, they will tell you, blood pressure. Yeah, blood pressure yako nzuri bana. Why do you say we have not examined the patient? You say blood pressure yake nzuri. Just because he was working like Dr. Beregi, I'm a hypertensive. I said, I'm a hypertensive. Then no activities in the peripheral facilities or communities. No human and financial resources to start implementation of a strategy on NCDs. We have institutions like diabetes associations. We have pamphlets, but these pamphlets that have been developed by the ministry are lying somewhere. Keep these pamphlets in public. They should be accessed by as many people as possible. No sense of urgency that NCDs are an important trait of Tanzania. Well, this could be a brushing of statement, but it's a true statement because we know, but then we do not take action. If we know it, then let's develop some kind of mechanism to take action. Public action is needed. Thank you so much. I would like to appreciate what you have done previously. Thank you so much.
Good afternoon, everybody. Normally, when the data talk to each other, you understand that what we are going to present, I mean, as a researcher, whatever you find that's good because there's no conflicting in the data. I'm saying that because from the morning presentation and what the analytical team has been presenting and what I'm going to present, they are going to complement each other, which is good, and I'm happy for that. So bear me if I'm going to repeat some of the information which has already been mentioned. Now, on RMNFHA and One Plan 2, the strategic direction which we have was The health system will be strengthened to provide quality services which will contribute to achieving the goal for ending preventable maternal, neonatal, maternal, newborn, and child death. And the second one was to ensure universal access to sexual and reproductive and adolescent health services. Now, what are the key findings from this strategic, overall strategic which we had? The key finding to start with, we found that there was slow decrease in fertility, which the analytical team have mentioned it in detail. And this was both in rural and urban area. But again, we found that there was high teenager pregnancies, which has already been mentioned. And we found that the couple-year protection rate has increased due to long-term family planning method. And most in these 8 regions where we went, women were preferring the implant, which is good. And that really confirmed what other researchers have mentioned, that the modern contraceptive is increasing. And really we found that it's increasing, and this is the method which the women were preferring. But we talked again to the to health staff, but the health workers, they have a little bit of a challenge in terms of insufficient knowledge and skills to most of the services which they're providing. Giving you just one example, and one classic narrative which were reported to us is, well, when a woman comes and they want to have family planning, normally we advise them to take what we have, which we can offer. Most of them, they want to have implant, but implant needs some special skills, which we don't have. So they have to negotiate win-win. Yes, you want implant, but what I can offer is this. So women tend to get what the health workers can offer, not what they want. And there's issue of private confidentiality in facilities. And this is due to small rooms, but multiple services, which is happening in the facilities. And I remember they were telling us, you know, this health facility was built a long time ago, whereby the population was small. But now we have got, the population has increased. But what about the rooms? The small rooms, they're still there. And yet, we've got a lot of projects, a lot of activities coming, and we are using the same rooms. So, why asking about confidentiality? Why asking about the privates? I'm saying this because that's the real situation in most of the health facilities where we went. Now, there's the issue of male dominance. And we have to sensitize men on reproductive health. We should not leave them apart, because for a woman to go and get a family planning, I'm just giving an example of family planning, there's several of them. To get family planning services, she has to get, most of them, they have to get approval from the husband. Now, if the husband is not supporting them, you can imagine. The sex provision for antenatal delivery, postpartum check has been increasing, as mentioned by previous speakers. Yeah, the quantity has increased. What about the quality? The quality indicators has not improved. And we found that CEMOC services, most of the hospitals, they're offering CEMOC services, but they are lacking theater and blood transfusion. And if you remember, most of you here are doctors. In order to have a CEMOC hospital, you have to have this cesarean section in it. Now, if the cesarean section is not performed because there's no theater, there's no blood transfusion, what about the quality? I mean, yeah, that came up. And also, pathogram. We all know the importance of having of filling the pathogram. But again, The insufficient use of patogram, neonatal resuscitation, and there's some belief in communities which hamper use of available services. For example, we all know the myth and misconception about family planning. And another thing which came up as a belief, or what women are practicing, when they're pregnant and approaching the term, they are using local herbs to kuongeza uchungu. How do I translate that in English?
Start contractions.
I want them to say it. That's what they're doing. Now, do we have a study which has evaluated the use of these local herbs and birth outcome? From the focus group which we had, they were associating, so-and-so delivered a baby who is already dead because, they are using this and that. And it is a common practice. And we know about neonatal health becoming a major problem. And as analytical team mentioned, there's an issue on neonatal health. Now, what about the improvement of this service delivery? We found that some of services, they're aiming on saving neonatal death, but saving neonatal life. But if there's no vacuum extraction, resuscitation, kangaroo methods not practiced, then those are the finds which we found. And checking babies during postnatal checkup. In some of the health dispensaries whereby they conduct deliveries, they will tell you, I've got one bed. So when a mother delivers, she has to go home to make sure that I've got an empty bed for somebody else who is coming. Now, if you've got one bed, you've got two pregnant women, what do? One has to go home. Now, if they go home, what about the postnatal checking? Are they coming? The good thing we found that the IMCI vaccination, nutrition monitoring is done across all the facilities which we went. And what they're doing, they mainly focus on curative services for the child health. Not all health workers have competence in providing standard IMCI. They were like, yes, we have the guideline. A nurse who was retired 2 or 3 years ago went to the training, and there's nobody who has gone to the training since then. And less attention for prevention. We found that the less attention to prevention for malaria, badness, nutrition, and feeding practice, diarrhea, and these are the common issues which was used to be common, but now they are less practiced. And there's no urban or rural differences. The urban-rural difference is still existing. Now when we talk about adolescent health services are improving in most of the facilities. And in most of the facilities, they offer adolescent-friendly services, and they say they are available. But still, less than 50% of facilities, they don't have privacy. Now you can imagine, a teenager comes to your facility, there's no privacy. I mean, just imagine for yourself. Are we welcoming them or are we chasing them away? Adolescent health is still far from reaching the target. There's little improvement in reducing teenager pregnancies, and HIV incidence among teenager girls is increasing. And gender-based violence is frequent occurring, but health workers are not equipped, are not trained to assist. And again, there's no data. We try to look on the data, and if please somebody's having that data, we'll be happy to have it. We couldn't find data on nutrition status of these teenagers, and we know very well these are the future mothers. What about anemia? And we know very well anemia in pregnancy, the consequences of anemia in pregnancy. And these are the adolescents, teenagers, yet no nutrition status. We found remarkable differences between regions in performance in RM and CHA. Analytical team have explained it very well. And the reason which we found were due to number of staff. I think they like staying in Dar es Salaam and those regions. And number of health facilities, we found that in Simiyu and the rest, the numbers of health facilities are, the ratio of staff and health facilities, as the analytical team has presented very well, socioeconomic factors, and other factors like leadership, support of NGOs, public-private partnership, and regional preferences in setting their agendas or implementation. Thank you.
Good afternoon. Good afternoon. I'm here to present Human Resources for Health, and we've been hearing since morning that the Human Resources for Health is the biggest animal that is failing us. And before even I go to the strategic direction, I just wanted to give, because we have those high table, the other high table, to give a little bit of history of where we have been. Before even we started the HRH, the Health Sector Strategic Plan 4, we are coming from the era where we would have been given 6,000 permits in the health sector, and we could only utilize 3,000. And the 3,000 that we utilized, when we posted people, we could have problems of even retaining them or them reporting. And apart from that, we had also issues of attracting people to the hard-to-reach areas, and that's why we had Mkapa Foundation helping us. So when we went to the health HSS before, we came with that history and lessons, and we subscribed to have adequate staffing of health facilities, because we have lessons on how to use permits and also how to attract people. And we also subscribed that we would have equitable staff distribution and retention, because we had history from BRN. We also said we will maintain high performance standards for employed professionals, and also we say that we will try to align human resources production with the priorities of health strategic, health HSS before priorities. Then what happened in the 4 years? What happened is, you've heard about the challenges of human resources, but we are trying to complement the reason why. So what we've seen in the field reports and also the analysis is that we have human resources for health planning, but automatically the way our human resource planning is done is typically administrative. So it does not give us the thinking that we are here and what kinds of projection we should have, and try to bring all factors together so that we can plan for production and also deployment. And then we had looked at why are we having such big shortage. We've seen that we need to have a moment to look at how we've established the demand. And we've seen that there is no workload-based planning, so we have tried to put our plans in terms of the numbers of facilities. So the challenge is we are increasing facilities, and even if we employ, the more we increase number of facilities, our gap will still widen. And then we have also looked at, we had a lot of implementation in terms of how we improve HRH information system from DHS, also from specific HRH information system, but we've seen that the information that we've generated, we've not sufficiently used to inform the HRH planning. So we've seen that the shortage is 50%, and also this affects the quality of work, my other colleagues have said, and certain cadres of HRH are really affected. We have cadres that are really in critical shortage, for example, the lab personnel and also the pharmaceutical personnel, and 90% of our health facilities do not have staff as per establishment. This is what we've seen from the field. And there is a still serious inequity in staff distribution between regions, but also within regions and also within the councils, because we have these geographical challenges in terms, developmental challenges, that there are councils that are disadvantaged, but also within the council, there are areas that are better within that council than the other. So it tends to attract more people in one place and not in other. And if people have read the magazine today, you'll see President Magufuli said he's going to shut down, kufuta, 30 councils, because after these councils have been formed, people don't want to go to the village areas where they are supposed to go. They still remain in towns. So this is the same problem with HRH. And then also there is another challenge in terms of the performance. Performance management in health service is not directly correlated with numbers of employed staff. We've seen the situation that we are seeing in Kigoma. We would have expected the indicators in Kigoma to be completely bad than the way it is in Arusha, but we are seeing different. So I think is the issue that need to be looked at. Is it, are there a performance management system? Is it accountability? Or there are other resources that are pumped in which are not calculated or counted within the system? And then in terms of our performance management system, we are not really it's not really working, neither at individual nor at facility level. We all know that we are measured by using OPRAs, and when we went for when we started HSS before, we had OPRA's challenges, and we expected would have improved. But still, the inherent challenges of OPRAs are still existing, but we have supportive supervision, which is not always done as planned, and also within the facility, we don't have internal supervision system that would improve performance internally. And then when it comes to human resources for health training, we've seen ourselves doubling the production. We've been able to produce around 18,000 HRH, but we have only absorbed 15,000. So it seems that there is no correlation between absorption and also and production. But again, the people, the newly trained health workers cannot be absorbed in the system. We know that, and we have seen. But also, not all training programs are having high quality education. Why? Because many of the training institutions do not have enough staff. We have seen that the curricula that are used in our training institution, out of 19 curricula, we had only 4 which are accredited. So there is an issue there. And also the practical skills needed for job are always insufficient. So they don't, people coming from pre-service, when they go there, they have to go into other training because there is a gap between what they learned and what is in practice. And then in terms of infrastructure for the training institutions, we've seen there are a lot of dilapidated dormitories, classrooms, and especially the challenges within the government training centers, and also even the skills lab are ill-equipped. Then we also looked at the continuing professional development. We've seen around 50% of the health workers that we met received CPD in 2018. But again, the CPD program is highly fragmented, it is not well coordinated, and there is no follow-up who got what training, despite having the information system that would have captured who got what training. And again, we have also another challenge in terms of the development. We have programs that is telling we are developing continuing education system. There are issues of accreditation of modules, registration of health workers using CPD and performance management. We've seen these are kinds of development. If they take off, they will revitalize the overall system of CPD. And that's it. Thank you.
Good afternoon. Let me just say I'm dealing with a subject which is a so many dimensions. It's a multi-sectoral, it's multilateral, multi-stakeholder, so that considering the ministry in a context of governance, governance is bigger than government. Therefore, when you're talking about governance, we are talking about other entities which are involved. The health sector is said to be strengthening leadership, accountability, and partnership. Now, that's a big challenge because you are saying that you are going to strengthen even leadership in other ministries to deal with matters of health. To ensure that all those who are involved as parties make their contribution. But then you cannot hold them accountable by your power to ensure that they contribute what they're expected to produce. Government will be inclusive, empowered, to empower communities, to involve partners, and being gender sensitive. Now, in the report that I gave to the team leader, there are three things which are here, which are not here. One is a whole of government governance, meaning that all ministries should have a responsibility in promoting and protecting health. And that's a big challenge to the ministry to ensure that all ministries are doing that. We understand there is health in all policies, the initiative, and is in place, and structures are being created to enhance that. But unfortunately, it is quite a challenge to the ministry. We have opportunities like decentralization by devolution. That means you go down to the community level, but there are also challenges. In this sense, you would say you want to have all of society governance. That means society or communities are taking responsibilities to hold the health facility managers accountable. And what is happening is these people who are represented in the health facility governing committees and boards should have information. To be able to hold somebody responsible, you must have information. Unfortunately, that information is impaired. It's facility level information and not necessarily community level information. The next one, please. Yeah, a key word here is also national level coordination. It was found to be weak because there was something which was missing. To hold somebody responsible, you have to be giving him or her what he or she expects to do, because you are talking about efficiencies, duplications, and so forth. If there was an implementation plan, then you cannot talk about people being efficient, ineffective, or delaying or something of the sort. Unfortunately, there is a gap here that the strategic plan had no implementation plan, what we call medium-term strategic plan. This one would have allocated which department, which directorate, which ministry would be doing A, B, C, D, so that when you go for continuous monitoring, you'll be able to ask these people what they are doing. But there was yet another gap. There was no communication strategy that would have been making a continuous follow-up to remind people what they are doing well or what they are not doing well. We hope that in the next plan, these two gaps will not be featuring. But we cannot say, for example, the non-communicable diseases is a multi-sectoral approach, but we can only see a close collaboration between the Ministry of Health and the Ministry of Education, to the extent that some efforts are being made to mainstream health-related topics into school curricula. But if you have industry, or you have commerce, or you have other ministries given permission to start industries that are going to be detrimental, be dangerous to the health of the population, and yet there's nothing you can talk or you can tell that particular ministry. It's a gentleman's agreement, and health in all policies cannot be done unless specifically there is a plan. Unfortunately, that thing did not exist. Sector-wide approach was found to be low, in the sense that some sectors, some donors or partners are involved in sector-wide approach. Some are not involved. When we went to do the study, they said, we also have our own regulations, program regulations. So some partners do not get into the swap because of the conditionalities of the funding agency or the funding government. Lack of focus on strategies and long-term development. Now, that project, that we said implementation plan is the thing that is causing that. Some technical working groups are dysfunctional or they are not working, but some of them are very active, but unfortunately they are seasonal. When there is near the budget, the finance and planning technical working group is very active. When there is this problem of maternal and child health, that becomes very active. Now, until there is a build run, then these are not. There are also problems with the shift of the government from Dar es Salaam to Dodoma City. You cannot ask a partner from Dar es Salaam to come here for a 2-hour meeting. It's not cost effective. Then I think we made a recommendation that some of these technical working groups should be held interchangeably in Dar es Salaam and Dodoma. There are too many technical working groups, and some of them are duplicating the working of others. They could be made to be fewer. Decentralization is identified as an issue, but not elaborated. We definitely have devolution, decentralization by devolution, but it is up to the level of the facility. What about going beyond the facility? D by D is generally successful to say that the CHSPs are being established and they are working very well and their plans have been said to be working. Given the recent government decision to have the direct facility financing, it has given power to the health facilities to make some decision. Unfortunately, those who come to participate, some of them for the studies we made, who come as community representatives are politically or appointed on account of popularity, not on account of not on account of knowledge or skill, so that they have lower leverage or less power to ask questions. So the power of knowledge is not functioning there. Of course, there are variations, regional differences exist. People are asking about Kigoma, Kilimanjaro, Arusha, why Kigoma working well? Well, I've been working Kigoma, and what I saw there, Kigoma is well endowed with the development partners, and the RHMT is very well using the development partners to fill gaps. For example, there was a project which I was leading when we went to do something in 6 districts. The regional medical officer compelled the funder to make interventions in all the 8 districts of the region. And it really worked well, and people have understood well we are doing health system strengthening. Concerning the CHMT supervision, mentoring, and on-the-job training, there is a problem here. We reviewed the curricula. We found those who had the governance or management leadership training are those who had taken MPH and a few doses in the nursing. But we appoint district medical officers to give them the responsibilities of leadership or management. And we assume that once you graduate from medical school, you're already a manager or you have the management skills. So management leadership skills is not a thematic area in the health sciences training. It's high time we also try to mainstream management on a serious note, management and leadership into the training curricula. On the job training, people are talking about mentoring and coaching. There is a whole academic area about mentoring, coaching. They talk it as a lip service, not as doing so. But unfortunately, we did a pilot, and when we taught people how to mentor and coach, we found that on a follow-up, we found there was a difference. When it comes to supervision, internal supervision at the facility level is very weak. For one thing, because of logistics, people in the facility, you find them that many of them are not that qualified. But when it comes to, let me just make a point, when it comes to the health centers, there's been an improvement in the sense that we find now medical officers, MDs, at the facility, at the health centers, and that has reversed the referral system. Instead of people going to the district hospital, the referral is the operations and other things are done at the health center. It's a recent development. The study we conducted in 2017 and the one that we made a follow-up in 2019, we saw that difference. Where the MDs had been sent to the health centers, the referral upwards were dropped drastically. And that means the quality of services and the accessibility were enhanced. There is also the logistics. Some of these people, some of these places are very, very remote. And the support supervision is operated under other charges. Unfortunately, other charges is a misnomer. It's operational charges. So once you cut down the operation charges, you can't. We reduced the monthly support supervision to quarterly supervision. But even the funding for the quarterly supervision are not there. In some places, the guidelines given are more than 100 items, and therefore these 100 items, they are operationalized over a period of 2 hours. That is too much. So you just slip through and it's a checklist rather than supervision to impart skills. And also found out that in that checklist is like a fault finding rather than on-the-job training. I think we need also to do that. The issue of performance management. Yes, we found quite a lot of improvement because they are being introducing, and the quality improvement has given more than 8 guidelines. Some of them are there, they are not executed. what we found to be executed very frequently is the operas. Very unfortunately, the operas is something very funny. If JAP is my boss, and boss JAP says that Munishi is not performing well, the boss of JAP will hold JAP responsible. Why is Munishi not performing? That is what we call in legal terms a bad contract, because I can always collude with my juniors to demonstrate that my department is performing. So it's not an effective mechanism, and I think one would recommend that let it be reviewed so that it can be skill-oriented, monitored more objectively than it is now. Unfortunately, there are also performance management interventions which have been made. RBF, people work very actively to meet the RBF conditionalities, but once gone, then they lie back and they do it superficially. We did a tracer study. We found that one dispensary had 40 beds, but we are also with nurses who can detect that this was not well done, and they found that people who reported that the facility, they were also recorded as having attended, which was very unfortunate. So there are still some gray areas in this performance management process that we have. This one? I'm not using this, okay. Government leadership collaboration with other stakeholders. The PPP is working well, except in some areas. It has really filled in some gaps. But there is a problem where, for example, the district designated hospitals were receiving quite a lot of support in this agreement, the agreement, service level agreement. Some of the money is no longer going there. There has been complaints in the morning here that facilities are being built closest to places where there are already private facilities. And when we probed, some government officials said, if I was your tenant and I'm capable of building my own house, why would you say no if it is the responsibility of the government? This is something which has to be resolved. It is seen as duplication, but from other angle, it's seen as a government responsibility to give services to the population, especially where some of the services are not affordable, some of the pricing levels. If there is an indicative price for fuel, is there an indicative price for health services? The ones that we find is the 2007 service level agreement. There is a price there where the prices are being overtaken by events. Do we need one at this time? That's another question. At the grassroots level, health workers have little time and capacities for collaboration with other sectors. Sector-wide approach is not really at the sub-district level. We have programs, donor-funded programs going to the district level and sub-district level, and also they take the attention of the facility workers, the in charges, attention to attend to them. So we need to take down the sector-wide approach and the collaboration, coordination at the facility level. We found some areas where some donors were doing the same thing in a particular community, and that, to me, was a duplication. Okay, I think what we are saying here is there are three things, if I may summarize. One, leadership training is required to be part and parcel of the medical curricula, health services training. Secondly, if we are going into the next, HSP, say 5, we need to have a midterm strategic plan to allocate responsibilities. Thirdly, we need a communication plan, and we are recommending that we need a communication officer who will be monitoring the implementation and to remind other people what they are doing or what they are not doing well. Thank you very much.
Thank you, Professor Munishi. I take over the presentation from Derek Chitama because he is abroad. Short on the healthcare financing. First of all, there were very high hopes in at the start of the HSSP4 that the health financing strategy would be finalized quickly with new initiatives and new ways forward for generating incomes, but that process has stalled in the past years. There has been done work for the single national health insurance, and we hope that some legislation will come out in this HSSP4 period because it is very important, as has been discussed. What has also been done in the meantime is developing the improved CHIF, which is giving better coverage for the clients and better conditions. And there we see a growth and a good potential. So while the national health insurance is still waiting, the continuation of improved ICHF is a very important step. It has been mentioned briefly that there is a growing resource envelope for health, but that is, if you calculate per capita, around $35 in the last decade. So the growth that is there in the budget is just keeping up with the population growth. Budget execution, there's a difference between the actual disbursement and the budget that has been made. It was 60% in the beginning, but now we see a disbursement of around 80%. So there's some improvement, but still it's not that you can count on the budget that has been allocated. You have to wait and see, because a lot of the funds are ring-fenced and cannot be used for other sources. What has been mentioned and what you will hear this afternoon also in the HBF evaluation is the delay in disbursements. Health facilities really need that money to go and buy fuel, to go in the villages to do vaccinations or to procure medicines. So the delays are not just an administrative issue, they are really affecting the health services. We see that the external support is slowly reducing, but on the other hand, there's a lot of budget, of plan support that is not incorporated in the balance. So we don't know if maybe some development partners are shifting their way of contributing to the health services, or if there's a real decrease in contribution to the health. With regard to financial management, we see good progress. The automated systems like FARS, PlanRep, and so on are functioning all very well. And there's a high approval rate by the Auditor General. So in terms of financial management reforms, there has been some considerable progress in the last 5 years. It has been mentioned already several times, but the direct health facility financing is really a very good improvement. And also there we see that the money is very well used. So it is not leading to abuse of money, but it is leading to better focused expenditure for the priorities that are identified locally. And the health financing governing committees, though they are still needing more capacity building, they play a role in the monitoring of expenditure, and that leads to increase of community accountability. So overall, in health financing management, there is improvement.
Will you move the slides for me? Good afternoon, everyone. So on behalf of the Health Commodity Midterm Review team that consisted of Siana Mapunjo from Ministry of Health, Matthew Mganga from PRALG, and Dr. Elizabeth Nyema, I would like to present to you the findings of the midterm review, particularly on health commodities thematic area. So in the HSPP4, the health commodities thematic area is guided by the strategic direction that says essential medicines and health products will be assured in quality, right priced, and efficiently delivered through MSD, and complemented by decentralized procurement engaging the private sector. Also, national stewardship and regulatory oversight will be of medicine will improve through quality assurance measures. All these are geared towards improving availability of health commodities, and I'm going to be presenting now the key findings based on the areas that I've mentioned under this strategic direction. So in this midterm review, we have witnessed a dramatic increase there was 31 billion that was allocated for medicines and medical supplies, and then it increased to 251 in 2016 to 2017, and then to 270 in 2017 and 18. So that shows the government is committed to improving availability of health commodities, but also the Global Fund. From the Global Fund audit report of 2018, it was mentioned that grants to Tanzania are largely focused on health commodities. So we are also seeing commitment when it comes to improving availability of commodities. We know insurance schemes, when it comes to these cost-sharing guidelines, the allocation for health commodities is also quite high, it's above 50%. So that shows commitment when it comes to funding in improving availability. But also better performance of MSD, including direct delivery to the service delivery points, and also framework contracts with suppliers. With the framework contracts with suppliers, MSD has been able to save costs, but also to speed the procurement process. And the holistic supply chain review that was done in 2017 had recommended improvement in fleet at MSD level, so that delivery to service delivery points can be fast-tracked. So from this holistic supply chain review and the costed implementation plan, MSD was able to receive 181 vehicles to facilitate direct delivery to health facility. So this is also a very positive finding of the midterm review. And then there's the bottom-up quantification, which is essential to assist in getting correct quantities or estimates of medicines and supplies, and it's applied now to all programs, not only essential medicines. It was mentioned earlier in the morning that the prime vendor is there to complement the government regular supply system, which is MSD. And we know that this has been rolled out in all 26 regions in the country, but the procedures are not always smooth. Why? This is because for the facilities to be able to procure from the prime vendor, they have to get out-of-stock notification from MSD. And this has been the major complaint from this midterm review during the field visits, that the notification does not come on time, so it delays the facilities to get commodities from the prime vendor. But also from this midterm review facility visits, in Geita region specifically, they complained that the prime vendor in Geita is not based there. And we know that prime vendors, they have regional contract approach, but they don't have, I mean, for Geita, there's no prime vendor based in Geita. The prime vendor is based in Dar es Salaam. So that prime vendor also delays commodity availability to the region. Also, another finding is that we know that essential medicines are needed for full coverage of the National Essential Healthcare Intervention Package, and this is not sufficiently available. And currently, the present focus is on most critical medicines, not the full package. Here we mean that, for instance, when we look at the MSD catalog, even if all the health commodities would be supplied by 100% or would be available by 100%, still the needs for hospitals would not be met. Only around 40% of the needs of the hospitals would be met. And we know that from the holistic supply chain review that was done, one of the findings was that the order fill rate for hospitals like Muhimbili National Hospital, which is a national hospital, is only 4% from MSD. So here we are seeing that there's a critical need of expanding that list to accommodate more items or more commodities that would address the needs of hospitals, hospital level and above. Another thing is that rational prescription of medicines is promoted using formularies and standard treatment guidelines. So we know that formularies focus mostly on medicines, and standard treatment guidelines are important to ensure that prescribing practices are rationalized. But during this midterm review, it was discovered that standard treatment guidelines are not available at the service delivery points. I'm talking about the new edition, the latest edition of 2017. It's not available in the service delivery points, which is a big surprise. Most of the service delivery points have the older versions of 2013, and those that have this latest version, they have them in soft copy. So it's very difficult to really, for a clinician to start using to use the soft copy version in prescribing. So they end up using the old version. So that's the big gap that was noticed. But also when it comes to, please go back. When it comes to national formula, the formularies, which are very important in providing detailed information about the medicines, contraindications, side effects, and the like, we found that in the 5 regional referral hospitals that were visited in the midterm review, only 3 had them and 2 did not have. So it's very important to have formularies, and it's for the medicine therapeutic committees that are part of these hospitals, they need to develop these formularies. But that is one of the gaps that was noticed. And also as the country, we do not have a national formulary that is up to date. And this is a WHO recommendation. The last version that we have is of 2005. So that's an area that we need to improve in when we're moving towards HSSP5. Standardization of lab equipment with lab procurement and maintenance contracts. So during this midterm review, as part of the recommendations of the holistic supply chain review, standardization of lab machines and equipment started, and it's ongoing. As of now, hematology and chemistry machines have been standardized. Other categories of equipment are now currently being standardized. It's ongoing. But then there's a challenge with imaging and radiology or surgical equipment standardization. So this was also pointed out in the holistic supply chain review, that there's no standard list of imaging and surgical equipment or radiology equipment, and even the way they're being ordered, they're ordered randomly, because these equipments belong to different specializations, so there is no coordination, a unit or a coordination team within the ministry to do that. So this is one of the gaps that has been noticed, both in the holistic supply chain review as well as the midterm review of the health sector strategic plan 4. So this is another area that needs to be addressed, And I remember Dr. Ntuli pointed out that they're interested in issues around medical equipment. So when it comes to radiology and imaging equipment, this is a gap and it needs to be addressed as we move towards HHSP 5. Another area of interest is research and development. So this is in line with promotion of local pharmaceutical industry in the country. We know that even the current leadership is promoting this, and there are favorable or conducive environment to enable this. We have policies in place that are promoting local pharmaceutical industry in the country, such as the National 5-Year Development Plan, but also TMDA, which was formerly called TFDA, has a help desk that serves clients who are interested in investing in this area. But despite all that accomplishment or the promotion of investing in local pharmaceutical industry, research and development is still developing. It has been observed that in the East Africa region, including Tanzania, local pharmaceutical industry focuses only on generic products, and with less investment in research and development. And this is attributed to many factors, such as weak link between industry and academia, and also research and development being highly donor dependent, which is not much prioritized. So that's also a gap that has been observed, and more investment will be needed to improve in other product lines, because we are focusing only on those less sophisticated products due to lack of expertise. Yeah, so I'm not done. So of the areas that were mentioned in the, can you go back? Of the areas that were mentioned in the overall strategic direction, one key area was on national stewardship and oversight. And I would like to appreciate the accomplishments that took place during this midterm review with regard to national stewardship. So we have had logistic management system, logistic management services transition to the government. So previously we had a logistic management unit in 2013 that was established to oversee or coordinate supply chain activities. And this was funded by USAID and Global Fund in terms of staff salaries and operation costs. But then it was transitioned now in July 2018 to LMS, and where LMS is part of the Directorate of Pharmaceutical Services under the Ministry of Health, and other roles became embedded within the PORAJ structure. So this resulted in integration of supply chain activities within the government. So this is an area that needs to be appreciated. But also, there was one of the recommendations of the holistic supply chain review was to standardize, have national key performance supply chain indicators, and the Ministry of Health, PORAJ, and other stakeholders have been able to do that during this midterm review in order to create uniformity in measuring performance of supply chain system in the country. So the KPIs were approved this year, by the Ministry of Health, and soon they will be disseminated to stakeholders. So that is an area to appreciate as far as commodities are concerned. But also, PORAJ, also with support of Ministry of Health, has introduced an initiative in collaboration with other partners in supply chain called Impact Approach, which refers to information mobilized for performance analysis and continuous transformation that brings together regional and council health management teams to work together to improve availability of commodities in their respective councils and regions by using data. So we know that we have different members of the RHMT and THMT with different product portfolios, but previously they did not necessarily sit together to discuss issues around supply chain. So through this initiative, they're able to sit together either on quarterly or monthly basis to look at the data and to come up with plans on how they can improve availability of commodities in their respective regions. And also, I would like to appreciate DHFF, the introduction of DHFF with the share of health basket fund channeled to facilities directly has also enabled facilities to be able to plan and procure health commodities using that fund. And lastly, I would like to talk about the health commodities, health technology technical working group, which is chaired by our chief pharmacist. And that is a high-level platform that brings together different stakeholders, from government, development partners, implementing partners, to discuss issues around commodities. And that has resulted in coming up with strategies to improve availability in the country. And this is something that is ongoing. Thank you.
So you use this one. The chair and invited guest, let me quickly take you through the two major components of monitoring and evaluation on what we really found during our review. Our review was guided by strategic direction. One was focused on data for decision making, utilizing web-based data collection and analysis, linking information systems, providing stakeholders access to data, quarterly feedback on performance to service providers and managers for immediate action. What we really found is that there has been a lot of improvement. We witnessed a tremendous development in the area of data systems, which actually guaranteed availability and reliability of data, that have allowed some analysis to be done and decision-making being made based on the available data. But on the other hand, we also found out that other routine statistics, like cause of death in the health facilities, are less advanced, which means it is not well developed to meet demands of some of the statistics required for decision making. Vital statistics systems are still not in place in Tanzania. At least we capture some of this data, but we don't have the system that comprehensively really capture this data. So this is an area that remains wanting. Automation is slowly progressing, but has not yet reached the primary health facility. So you could see at the highest tertiary levels, secondary level, but at the primary level, there is still much need to be done. There are still many parallel information systems, which actually, instead of becoming a solution, is overburdening some health staff. The streamlining health information system have not been effective so far. And some of this development have been funding agencies driven, and which has been the reason, some of the justification where we have several systems that does not really well integrated to provide information that are required. Sometimes you find some of the information varies as you get the same data from different systems. Other systems like notifiable disease surveillance, sentinel surveillance, demographic surveys are important for understanding epidemiological trends, but some of those are not optimal, which can, for example, hamper disease outbreak control. So it's not very reliable to actually provide immediate information about things like disease control. The culture of using data is still also not very good. We have a lot of indicators from different strategy that exist, but managers, leaders do not really align they don't follow them much. They do implement to get results, but they don't tie the results well with the indicator that have been developed in various strategic. And some of the data in the sources that are available are outdated. So this also provides difficulties to rely on this data for decision making. So despite that, probably the culture is undermined by some of these factors, that available of data that are updated, but that are well updated, but also the reality that we were not used of making sure that what we do is very well aligned to the indicator that we have put in place to guide our action. In the area of ICT, the strategic direction that guided our review, where the health sector will embrace the rapid development of ICT for improving administrative processes, patient-client recording, communication. The Ministry of Health will stimulate the development and the guide interoperability of the system. What we found out in this area is that there are more than 180 apps in health sector in Tanzania, developed in a parallel, sometimes with similar objectives. So we have found there is a lot of apps that are developed, and some of these apps are not really integrated. There are three major areas we found out. You have systems that are actually facilitating, providing information on the administration issues. We have the system that are capturing medical record data. We have systems that actually inform about human resource, but these systems are not well integrated. They do not communicate. So this creates also a problem in actually using this data for decision making. Some of the systems are disintegrated and do not provide information that could easily be used for decision making. Health workers' experience versus the mushrooming of ICT in health is really overburdening, becoming a burden instead of being a solution to problems. Some of the hardware are not always provided for apps, re-entering of data because the system do not communicate. So health workers are forced sometimes to enter data into different systems, even similar data. The National Digital Health Strategy, which is there, gives guidance in further development of the ICT in health, especially interoperability of the system. And we have seen some initiatives currently going on to actually integrate the many systems that have been developed in the past years. We have the Muungano Gateway. I think it is still under development. And we have the Health Information Mediator, which actually is trying to integrate and create some sort of interoperability of different systems that have been developed in the past years. Besides investment in infrastructure and the content, we think that more attention is required for sustainability and capacity building. Because we have the systems, but to be sure that the system, the data that we're getting could continue, there is an urgent need of ensuring that we have the sustainability strategy that could keep our system continue to provide the quality and the data that we need for the decision making, and as well the capacity, because of things are changing over time, and then we need continuous process of actually building the capacity of health workers whom are relied on to actually collect this data and enter into the system. The wealth of data that will become available should be used for better management of health services by integrating ICT in day-to-day management. This is only the emphasis of creating a culture of data use for decision. The data, we generate a lot of information, a lot of data, but we need also to make sure that the information that are being generated really are used for decision making. I have tried to be very quick because I've already seen that we are behind the shadow. So I think I used less minutes than all of the presenters already. Thank you.
Naogopa kuzungumza. Moderator, can we simama kaa mara tatu alafu tuzungumze? Please.
So he's requesting a leg stretch break where you are sitting or standing, not going out. So I'm not a teacher like Adija Kweka. I would have told you to go around, just move.
Thank you for those who have kept the time. Mesimama sasa kaeni. Please, let's go ahead. This is about community, so the language is different a bit. And I'm standing here to present the community work because the colleague who did work on community is absent today, and the team leader thought I should be the scapegoat. I don't know why he chose me to be the scapegoat. First, to commend the sector. The finding is that the beginning of HSSP 4 saw a community-based healthcare policy guidelines already drafted by the sector, so it gave a good start of HSSP 4. Then they went quickly into defining a costed strategy for community-based healthcare, and then by 2017, they drafted an implementation design for community-based healthcare, and the responsibility was shared with PORAG. That was a very good way to bring also the community work to be more integrated, holistic, going by the spirit of swap and coordination. Otherwise, the incoordination at community can be quite costly, or if it has not been so far. The community-based health program, I wish to say, well, yes, it has been designed, but it has not taken off in a comprehensive manner. Community health workers' role, functions, incentive packages, different practices continue to exist, and there is not really a clear direction on sustainability, because it tends to be driven by a plethora of actors who individually go to districts, and they may not be well coordinated at districts. They implement various initiatives out there. Getting a cadre of professional community health workers was seen as a way to do away with the old community volunteers out there and not expect just one uniform approach dictated top down. So really the issue here is adaptation rather than adopting the guidance. screening, that has been more the emphasis, but ideally the design that was put in place by the sector was supposed to be more of health promotion rather than the other two. A mixed approach, but with emphasis on promotion. That emphasis on promotion has not come through. Health information is provided, but not reaching all communities. Mind you, with this community work, that is the avenue for reaching all households with quality care. We should not be theoretical with that, we should be practical. So what have we found? Community empowerment to solve water and sanitation or nutrition issues are often taking place with limited or little involvement of health workers. Some health workers are involved. I'm talking here ward level much more than a district level, where you find Bwana Afya who is well committed to his job. They tend to work very well with other sectors at the ward level, and they push forward the WASH, water, hygiene, sanitation, environment, sanitation issues. And things move because they collaborate as a team. Where you find a Bwana Afya not doing his role or her role, the teamwork is lost, and the water, sanitation, hygiene issues are kind of falling in the cracks, just because there is no actively engaging person who is determined to see that front move forward. The same goes for nutrition. We find that there are inconsistencies sometimes. In some places it's clear what we're doing, some places it's not clear. Health workers do not have time and competencies to deal with the social determinants of health. And that's why we are having a cry, for instance, on NCDs. If we do not make sure that the people know the importance of changing the eating habits, the drinking habits, the safe sex practices, sexual reproductive habits, the stigma and discrimination on some of the illnesses, stigma sometimes even caused by ourselves as health workers and not so much by the community. The other day I heard somebody was saying, yeah, somebody when they hear this person has MDR TB, the health workers start to create excuses for not paying attention to that one. We have to change our habits on drug abuse. Drug abuse is happening, especially in our urban areas. Our habits on use of roads, safe reuse of roads, driving habits. So I mention all these habits just to show how wide the social determinants of health are, and yet this is not an area where most of the health workers are competent or willing or making time to engage effectively. But fortunately we have associations which try to move this front forward, bring to consciousness what needs to be done. And here, please allow me, Chair, to mention the Tanzania Public Health Association and the other associations which are actively promoting health in this country for doing exemplary work. But we need to do more if we need to tackle the NCDs on an effective footing. Traditional beliefs that hamper health continue to exist. Let me just repeat, but don't get tired. male domination is the disease of our time because of the traditional roots. We need males here, even if you're going to hate me, tubadilike wanaume. It will be for our benefit. If I was talking like that in a public gathering, you'd see how well or how unwell some men would leave the meeting feeling that they've been like condemned. But when I look at what happens in the bumper harvest regions, which were mentioned this morning, Rukwa, Njombe, Songea, all those are bumper harvest. And then you have a lot of malnutrition there. You have a lot of stunting there. A lot of food and a lot of stunting. What has gone wrong with our intelligence? It's very easy to see the gender differential in there. When women in those regions go to markets, who is feeding the child? The distribution of labor across gender, if you do a 24-hour calendar, you'll find that men are going to the pub to drink very early in the morning. Men are doing all kinds of small activities. They even list going to bath as an activity, while women, the women's list is so much full of substantive work that they even forget to list care of the child or feeding the child. I'm belaboring that because in that labor differential, if you do that exercise at community level, they discover for the first time that the wrongdoer is the labor distribution between men and women. If you correct that, there is somebody who will take care of feeding the child. Please, we need to understand that there are some traditional beliefs which are a curse to the health sector. But on the same vein, I wish to say that's the beliefs, but there are traditional practices which are positive, which we are not researching and documenting in order to use them as leverage for health interventions. There are traditional practices which can be used, which are positive, to promote health. So we have to take a balanced approach when you use the term tradition. This one on nutrition, I think I've already given a bit of highlight, but let's know that there is the Nutrition Action Plan which has been rolled out. It has come as far as the ward level, but at the ward level, there is still not real activism enough. But let's remember the 1,000 Days Initiative has percolated. We need to see the benefits of that, and that one is a step in the right direction because at least the severe and acute malnutrition are addressed within that one. And we saw that it is already in place. I think this one is for my colleague to come and hammer home the discussion on gender, which I tried to start.
Asante sana, Madam Chair. I will have to start with where he ended. Watumishi wa afya tubadilike. Can we say that? Tusiseme tu wanaume tubadilike, watumishi wa afya tubadilike. Watumishi wa afya tubadilike. Watumishi wa afya tubadilike. Watumishi wa afya tubadilike. At the background of the gender study was the situation in which we have unequal health outcomes between men and women, and between boys and girls. You have seen statistics here. The maternal mortality is still high. The teen pregnancies are very high. The HIV infections among adolescent girls is still not going down in the same level as that of boys and in the same level as that of adults. And we know that the situation is due to the unequal gender imbalances in our health system. We were tasked to look at the health strategies, health sector strategies and policies to determine if they have if they are able to meet, to help reach the indicators regarding gender in the HSSP4. We turned around and said, let's start with the HSSP4. HSSP4, we discovered that in itself, after putting it under the gender responsive assessment scale that was developed by WHO, we discovered that itself was gender blind. It did not have specific gender indicators that would be helped to be reached through the other policies and guidelines in the health sector. So it was a wake-up call. We looked at other documents and saw that the One Plan 2 and the National Plan of Action for GBV were the exemplary ones. They are the ones which had concrete steps and actions that would help to reach, to integrate gender in the system. The effect of having gender blind documents, gender blind guidelines, gender blind strategies is that we also have a almost gender blind health information system. Our routine data is not sufficiently and consistently providing gender aggregated data in our system. And also even the data that is available, the data that is entered, desegregated by sex, is not analyzed properly. The result is also that we have the well-awaited for health financing strategy that is also gender blind. The draft is gender blind, and we need to have this document redone or reviewed to make sure they are gender transformative, they are helpful in this process. In the area of health services, we noted that there were mainly three problems which we saw: that we had gender blind infrastructure. Our health facilities did not provide confidential places with confidentiality that are able to attend specific needs of men, specific needs of women, and specific needs of adolescents. Most of them are lumped in small rooms, and they're filled with people, and it is not easy to provide services that are private, with dignity, to be able to attend some of these things which are at the core of the lack of utilization of some of the health services by these individuals. Also, the knowledge, gender knowledge in the health sector is very low. We asked many people, DMOs, members of the DHMTs, many of them do not understand gender issues and are not able to identify bottlenecks of gender and factors that lead to unequal gender health outcomes. And therefore, they are not able also to advocate for increase of budget to support gender-related activities at the community and health facility levels. We saw provision of respective maternal care as one of the areas that needs to be improved. And these are the things that also lead to deliveries happening at the homes and outside the health facilities. As regard to gender unequal norms or practices in communities, our societies, even the health sector, is male-dominated. We have a staff that is mainly male-dominated, just like in other countries. But the norms and social norms in the communities are the ones that affect the utilization of the services much more seriously. We have low health-seeking behavior by men who decide when, how, and what time women should go and get services. In some of the areas where we went, even during emergency times of delivery, some women would not go to the health center unless they have been permitted by their husbands to go out. And in some cases, husband, one gentleman was furious and he wanted to fight with the doctor because he stayed too long with his wife. So they don't want, some of them do not even want their wives to be attended by male doctors who are the main service providers in some of the areas. So as a result of lack of decision in ANC, family planning, we have high rates of gender-based violence, rape, and abuse done at families, by relatives, and in many areas. And this is very serious as you go to some of the rural areas, and information is available in the report. But then we have lack of GBV kits in most of the primary level facilities, and lack of capacity of some of this staff to be able to attend the gender-based violence cases, as well as lack of coordination among our government branches. We were talking about police, court, and the ministry itself, or even between the two sides of the ministry, the community development, which is highly underfunded to be able to deliver gender-related activities, and the other side of the Ministry of Health. So improved coordination would be very useful in improving the situation in the communities. And all in all, when you look at this, it is because of the gender expectations, norms, and power dynamics at the community, as well as the attitudes, behaviors. And these are the ones that we should target at community level. We should target to change gender norms, because they are the root causes of the imbalances in health outcomes that we are trying to attend to. Thank you so much.
Madam Chair, we did an analysis of the strategic objectives in HSSP 4, and the 5 objectives are mentioned here of quality, equity, collaboration, innovation, participation. Because of time, I'm going to skip that, because you already hear so much from my colleagues that we think we can jump to conclusions. The conclusions are that the performance in the health sector is improving. Really, congratulations have been given this morning by partners, by other stakeholders. You have heard from the consultant. There is increase in productivity, increase in efficiency, and increase of quality. So we really find that our major conclusion of our midterm review. We have heard the bottlenecks. I will just mention them briefly. Coordination, harmonization, human resources are the major problem that affect all areas of work. We need a single national health insurance, not only because that is better for access, but also to do away with the exemptions and waivers that are not really focusing on equity. And community empowerment is an important philosophy in Tanzania throughout, and that needs to be enhanced. So recommendations, tomorrow we are going to talk in the groups about recommendations. So I just mentioned them very briefly. You have heard them from the consultants. Strengthen governments, strengthen coordination, work on SWAP, take D by D further. Financing, get the health insurance as quickly as possible in place. Human resources, there you will have a high-level meeting in November as announced by the PS, and we really to capacity training and continuing professional development. Infrastructure is mentioned here this morning as an important development, but it should go as a total package together with human resources, with finances for medicines and equipment and so on. So it is important to look at it as a complete package. quality is improving, but by pulling together the different initiatives, we think that there can be even more results. And disease control programs, we heard they are performing well, but there are areas for improvement, as well in the area of gender, what was mentioned. ICT was mentioned as an important way to facilitate better healthcare if the systems are more collaborating. So those are in brief the conclusions and recommendations, and I would like to thank my team for the excellent work that has been done in the past half
year. Thank you very much, Yap and the team. That was a very good participatory. They say if you want to go fast, you go alone. You want to go far, you go together, and you have done it. And you went really far until the discussion time was eaten. So we had made a decision to revise the program in between, but at the end, because they also took more time, we made another decision. So what you are going to hear now, I believe we can continue until the morning, but it is better to break for lunch. We break for lunch, we come here, as I said, at 3 goals today, to hear the analytical review, to hear the MTR and the basket MTR. We are going to hear those. So let's go for lunch, strictly 1 hour, and come back. Karibuni.